This conference will now be recorded.
We'll try to keep today's session a bit, it's brief and it's super interesting. So hopefully you guys can keep up. And what I have decided to do with subfertility is that we will take it in three different sessions so that we are able to go into each of the factors into a bit more detail. Okay. And so all you would require in order to answer any question that comes up in your part two is going to be covered in these lectures in a great uh, bit of depth and detail so that you wouldn't miss on any questions which can come up. Okay, so with that, the relevant TOG articles and the guidelines which are necessary for subfertility module in part two, I have enumerated here. And of course, the most important chunk of questions that you're going to get is from your NICE guideline. And each and every sentence, every line from the NICE guideline, that is fertility problems, assessment, and treatment, this one is going to be extremely, extremely important. And you have to understand not just the interpretation of it, and the questions will be twisted in such a manner that sometimes, despite having read these guidelines multiple number of times, you can still get confused and you will still get the answers to the EMQs and the SBAs wrong. All right. So the trick is to know the guideline in such detail, and we do know that a NICE tends to give the information in a bit of a jumbled manner or slightly more haphazard. So I have tried to streamline this information for you so that all the relevant flow of thought is maintained and you can understand the concepts really well. Okay, so to with that we can start off. All right. So now, for fertility, we know that the basic requirement here is that the sperm needs to meet the egg, okay, and that's what leads to fertilization. Fertilized, embryo then comes up and it implants inside the uterus. All right. So we know that we are essentially going to require, or these are studied under the factors that are needed for fertility are studied under these four broad topics, which is your sperm. That is, of course, the male factor. All right. So we have the male factor, which is if the sperm is deposited and is in good quantity, then it should be able to via the second factor, which is the patent tubes. Patent tubes should be able to reach the egg, okay, which again the patent tubes are able to pick up. Functionally, normal tubes will be able to pick up and result in a fertilized egg, which forms the embryo. Lastly, we have our uterine factors, and of course, we have the egg, which is essential. So, ovulation. All right. Now, when all of these factors are tested and they are normal, we get our fifth category, which we studied under, which is called as unexplained. All right. So far, we all understand this process, and now you can, in your mind, create sort of template for you to understand how we are going to investigate, not only investigate, but also treat under these factors. So each of these factors we are going to look at. Hmm. Time and again, I shall be referencing back to this flow chart. Okay, it was in one of the older blog articles, particularly the tubal patency tests and where and when to utilize the tubal patency test. So there was a whole article on it, and there was a brief summary of the sorts given inside the TOG article itself. It forms a nice visual summary for you to really look into because it tells you what are the different percentages. Now I've blocked out these uh, which had confusing figures for you because you have to remember the figures from the NICE guidelines only, and they are asked. Okay, something in terms of numericals, if you want to remember in subfertility, you should remember that they do ask the percentages of the contributions of the different factors which cause subfertility. And not many other figures are important, but yes, then your normal values, okay, for analysis, they are important. And also, like the percentage contributions of the different types of male fertility factors, those numericals will be important. So those I will go into detail as well. But you try to remember here that the different contributions from factors like your unexplained male, anovulation, tubal factor, these are very, very important. They are given at the end of your nice guideline in the write-up, but questions do come up from there, and each of them has been separately asked in the past, okay, in single best answers, not AMQs, but single best answers at least. All right, so this chart I'm not going into depth as of now, but we will come back to it and reference it intermittently as well. So, understanding the problem statement, first of all, we should know that subfertility affects 1 in 7, that is 15%, 15 to 16% on an average, heterosexual couples in the UK. This percentage again is important. They can either ask you in this particular number, that is 1 in 7, or what percentage it translates into. So roughly it translates to 15 percentage. Okay. And as I have said earlier, the different contributions from the factors also very, very important. So the male factor causing an infertility or subfertility is about 30%. We do know that this was corroborated by the 2013 TOG article as well. However, there was a later publication which increased this percentage slightly. Do not get confused with that number. You still have to, for the purpose of your exams, stick with 30%. And a combination of the two, male and female, is 40%. Okay. So this is what you are going to mark if asked in the exam. All right. So just remember these percentages. Additionally, we have to remember about the unexplained subfertility contributing to 25% of the cases. Here on, we will have all the factors in investigation known in these cases, and still 25% will not be conceiving normally. Okay. Ovulatory again 25%, tubal damage about 20%, and uterine and peritoneal disorders is about 10%. So now you can see the reason why I have blacked these things out here so that they correspond exactly what figures you need to remember for your SBAs. Okay. All right. So these are the figures here. I have nicely drafted a pie chart as well for you to get a visual representation. If we were to ask you which of the following factors is the highest in terms of contributing to subfertility, what should your answer be? That's a trick question. Things like these will come up in the exam and confuse you. You should know that you shouldn't try to find the single factor here. All right. If they are asking you the highest contribution from, remember that it will be from the combined, that is male and female coming together, up to 40%. Okay. And then you have your male factor, which is 30%, which is the next highest, followed by we have ovulatory and unexplained, and then lastly we have tubal, uterine, and peritoneal. Okay, all right, easy peasy. And this 1 in 7, this is a pie which has been cut in 7. So 1 out of 7 couples will be suffering from this. All right, you guys with me so far? Any audio difficulties? Hello? Yes. All right.
Yes, okay, ma'am.
Now, thank you. So, um, now the first thing that you must know is when a couple walks inside your clinic, okay, the first question to be asked is, are they actually really having a problem? So people might come walk into your clinic in the UK and then they might be worried about conceiving. They might be trying to conceive or they just want basic information about conceiving. So in this situation, there are certain things that you need to be aware of because questions can be asked by your part 3, role players as well as in your part 2 exams also. You should try to remember these, and oftentimes this will be tested. This particularly, in fact, was cited in an EMQ, and there were 4 different scenarios, in fact, 3 scenarios, and they said pick out the most applicable percentage out of these. So you have to read your question very, very carefully. All right. So, because I will tell you how they will frame it and confuse you. The first thing you must know is any couple that comes in and those individuals who are perfectly healthy, they're not having any sort of medical conditions, they don't have any risk factors for having any male tubal ovulatory disorders. Okay, so they are history-wise perfectly, completely normal individuals. If they are trying and the female is less than 40 years of age, remember this age group here, which I will mention versus another age fact that I will provide for you slightly later. So this is information provided the woman is less than 40 years of age. So what you must tell this couple is that if they are trying by regular vaginal intercourse, that is, they are having regular sex, okay? In those individuals, you expect that they will conceive in 80% of the cases within the first 12 months, that is 1 year. Okay, this percentage pretty straightforward. Straightforward. However, what they will ask you is a couple didn't conceive in 12 months. Okay, they're here asking you what is the likelihood from the remaining individuals who will conceive in the next 12 months. See, the phrasing of the question changes the answer, okay, to 50%. Half of those who were left behind will conceive. So it's 50% if asked in that manner. Now, in an EMQ, they have also asked in the past, what is the cumulative pregnancy rate if you wait for another 12 months? So what we are asking here is 12 months we have tried. Okay, they have tried, they didn't conceive, but they are asking what would be the cumulative pregnancy rate in another 12 months. What is cumulative? Cumulative means added, the total. All right. So, what does that mean? That means 80% of these individuals they would conceive in 12 months. However, half of the remaining, what is remaining? 20%, right? So half of those, that is another 10%, would conceive. So 80 plus 10, we get a cumulative percentage of 90. So please be careful while reading what exactly they are asking. All right. So, for these figures to turn out the way that they do, you can't be having a couple who is probably being intimate once in a month, twice in a month, right? You need to have them regularly coming in contact. So, as a general advice, we tell to have intercourse 2 to 3 times per week, provided they are not having any sort of sexual difficulties and issues on those lines. All right. Now, sorry about that. The next thing you should know is you should advise a couple that fertility trends they will decline with age in both the sexes, and this decline is more pronounced. We all know this in females over males, but it declines in both the sexes. Hmm? Now, you should also know that we were talking about a couple who was having vaginal intercourse. That means they are having sex. There may be other individuals who are not capable or not in a situation where vaginal intercourse is possible. Okay? Can somebody give me an example in line with this? When couples are trying to conceive but not having vaginal intercourse. One answer, just to show it. Dr. Pallavi?
Yes,
Hello?
ma'am. Hello.
Yes.
Yeah.
Can you give me an
Madam, any
example?
problem? Yeah. Any problem with the female we're having that to for the in the ililectomy position where penetration may not be possible? Any fracture or something to the female? Or if the male is HIV positive or some sexually transmitted diseases where sexual intercourse should not take place? Hello? Hello?
Hello, am I audible now? Hello?
Yeah.
Yeah. Okay. So, yes, good examples. Perfect. But you should know, and I have provided a list here for you. Try and remember this. Okay. Mm, all right. So, there are individuals who will require this sperm, as in the first slide we saw that the sperm was one of the basic necessities. All right. So, you should try and remember that though we are normally talking about couples who are having vaginal intercourse, we also have couples wherein they cannot have sex for whatsoever reasons. One reason could be male sexual dysfunction, so such as ejaculatory dysfunction, erectile dysfunction, retrograde ejaculation, okay, loss of libido, and so on and so forth. So, all these reasons may be why they are not able to uh, result in an ejaculate reaching the vagina or the cervix at all. Okay. The second thing you have to look at is female sexual dysfunction. Now, you mentioned fracture, like it was a very specific sort of situation, but it's not like a permanent or ongoing issue. However, you can have things like vaginismus, or as you have said, like if that fracture led to something more, permanent in the female, making it impossible for her to have intercourse, then it's another applicable situation. But more commonly, we have things like vaginismus. Okay. Then again, we can have same sex female couple, that is lesbian couples, and single women. We can have cryopreserved male gametes. That is, if my partner is now subfertile for whatsoever reason, like he had chemotherapy or radiation, but they have done, freezing of the sperm prior to this, and they have kept it in the bank. Okay, so that might, for the purpose of conceiving, we might have to thaw and utilize in the form of a insemination. Okay, insemination. And of course, we have other infectious diseases that you do not want to transmit to the female. Okay, for example, HIV needing sperm washing. All right. Additionally, IUI or insemination may be required in donor insemination. You're not using partner sperm, but donor. In cases of azoospermia, it could be either obstructive azoospermia, non obstructive azoospermia, or women who have declined to use in vitro fertilization or ICSI. We will be discussing in detail about that later. But for here context, just remember women declining in male subfertility cases, use of in vitro fertilization may want donor insemination as well. Okay, and if there is a risk of transmitting infections, as mentioned here, one of the examples is HIV. If they want to use donor instead of using sperm washing, they want to use donor, then, or genetic diseases, which are severe genetic diseases to be transmitted to the baby, and you want to prevent that. So you're using a donor, or severe rhesus isoimmunization. Again, you are using a donor. Okay. Will you guys remember these? Okay. These are almost all encompassing, and hardly anything you would miss out in terms of usage of artificial insemination. All right. Okay. Am I clear? Do you want me to go over
Yes,
anything,
ma'am.
Dr.? Yes. Okay. All right. So, in these cases, when the couple is requiring insemination, now remember there are three types of insemination. They will confuse you with options there. They will say intracervical insemination, intravaginal insemination, intrauterine insemination. Different options will be given to you in EMQs, especially. You don't read up carefully, and you might end up marking the wrong question. So, you should remember that as far as the NICE guideline goes, you are dealing only with IUI, not cervical, not vaginal, IUI, intrauterine insemination. That's the only kind which is considered acceptable in terms of therapeutic usage by any UK clinic. Okay. All right. So the other sorts would not be marked at all ever in any answer. Okay. So if a couple now or a woman is trying to get pregnant through IUI, you should tell them that the success rate is with first 6 cycles. This is 6 months or 6 cycles of IUI. 6 cycles would be 50%. Half of them will conceive. And if, say, they do not conceive in the first 6 and they try another 6, then the cumulative rate is 75%. Again, if they ask you, what is the number or percentage who will conceive in the next 12 months? It is 25%. So half of the remaining, 50% of the remaining from this half would conceive in the next. So making 12 cycles, cumulative pregnancy rate of 75%. Again, important figures. Now, the best insemination method which NICE accepts, and as I've told you, IUI using fresh sperm is better than IUI using frozen thawed sperm, but sometimes you have to use frozen sperm, and which is way better than intracervical insemination, which is no longer recommended by NICE. Okay, so Now, as we have said, the intercourse frequency, which we ideally explain to anybody, is 2 to 3 times per week, and the ideal timing for IUI would be that around ovulation. Okay, around ovulation. All right. So the next thing that we do with this couple who has now walked in and who's questioning you about their fertility prospects is that you need to take their history. All right. Now, this is not categorically stated in your NICE guidelines, but it comes up from all your different talk articles and practical knowledge and how you need to evaluate essentially. What NICE repeatedly says is that in a couple who is absolutely not having any risk factors or positive answers to any of these questions or of abnormalities, okay, in those situations, then you can advise them that these are the expected rates that they will conceive at. However, couples can come who might have menstrual disturbance, okay, or the male has had some chemotherapy in the past. In this situation, your typical answers that you're giving here are not going to remain the same. Okay, this is only applicable if everything is hunky dory and couple female is less than 40. Okay, remember that. Now we must understand what is the basic history which you need to ask in terms of your fertility. So we have to first establish if there is a fertility concern or not. Okay, to that end, Dr. Rashmi, can you tell me when will you start calling it subfertility and when will you start investigating as per NICE, if you have any idea about that? Dr. Rashmi?
Yes, ma'am.
Yeah.
We should start investigating for subfertility in 1 year after if the couple is not able to conceive in 12 months, and
Okay.
2 years unprotected intercourse without any contraception, like unprotected. Two years we can give the time for a couple for unexplained infertility.
Unexplained. Okay. Okay. All right. Yes. So, very,
And
very important figures there.
to be done in 1 year.
Yes, to be done in 1 year. All right. So now we said the couple who was having intercourse will be investigated at the end of 1 year. What about the couple who wasn't having intercourse at all? So, who was trying with your intrauterine insemination? They will be investigated after 6 cycles. Now, there is a little bit of a tricky situation there where a NICE guideline reaches towards the end and then it tells you that there are different categories of indications of the IUI. Okay, and for these different categories of IUI indication, your investigation timeline changes. Mind you, pay attention to that timeline. Okay, so it is not always going to be that 6 months, 12 months period. All right, your investigation for IUI will differ depending on what is the indication for that IUI. All right, so I'll go into that as the slide will come up. All right, up as we explain IUI in a bit of more detail. But as a general rule, as of now, remember that if couple not having any issue, same-sex couple, lesbian couple, then single mothers, then if someone is HIV or infection discordant couple, sexual dysfunctions in either the male or the female. Okay, in these situations, if you are offering IUI, you offer after you have taken your history and ruled out everything, you offer IUI 6 IUI cycles, and then if that does not work out, then you start investigating. Okay, so that is what we will remember now, but there are exceptions or changes to this rule. Okay, that also you will see. So what is the basic history? First, duration. You need to confirm that they are having frequent sex, so 2 to 3 times in a week, and if they are having any difficulty. So that's it. All right, so that tells you they are in contact. They should not be using contraception. That also you have to confirm on history. Next comes the woman's menstrual cycle, regularity. If there has been any dysmenorrhea, any intermenstrual bleeding, heavy menstrual bleeding. Again, I have made notations here. So heavy bleeding or pain will tell you about fibroids, endometriosis, things of those nature. And regularity of the cycle essentially tells you about ovulation. Okay, so it is a proxy indicator of ovulation, but it is not enough by itself. Okay, so we as a basic screening are taking this menstrual history. Then if there are irregularities, you look into if there are other hormonal issues which can be pointed towards, such as your thyroid and your prolactin. Okay, why? Again, guideline tells you that if there is any headache, galactoria, or irregular cycles or anovulation, you must also do serum prolactin. All right. Similarly, you do not do thyroid function test routinely for everybody who's coming to you with a concern, but you do if they are having symptoms of hypothyroidism. Okay. In the male, you have to take a full male subfertility history, which I have gone into detail slightly later, as we will be discussing male subfertility in depth today. Okay. So, then of course you have to rule out if there are risk factors for tubal diseases such as we have any PID, sexually shared infections, any ectopic pregnancies in the past, endometriosis and the symptoms, pelvic surgery, etc. And other fertility factors like any chronic illnesses, smoking, alcohol, drug use, what is the BMI, etc. Okay. There is something in terms of general advice that you must give. So far, everybody on board? Dr. Suchita, Dr. Niro, Dr. Prabhati?
Yes, ma'am. Yes, ma'am.
Yeah. All right. So, in terms of the general lifestyle and the measures which need to be advised to a couple who comes and just, is sitting down and discussing with you about fertility, is factors like your alcohol, smoking, caffeine, obesity. Now, these have often been asked in one or two SBAs, single best answers, and what they will do is they will usually give true or false in that sense. They won't give you like choose what is the best. For example, they will give statements, and you have to pick out what is the relevant one or what is the correct one out of them. So you should remember that, okay, mild or even moderate alcohol intake does not affect semen parameters, okay, whereas heavy alcohol intake does in the male. Okay, this is defined as having less than or equal to 3 to 4 units of alcohol per day. So males are allowed per day 3 to 4, so 1 2 3 4. Okay, remember women it's 1 to 2 drinks, but it 1 to 2 times per week. Okay, 1 to 2 drinks 1 to 2 times per week, versus in the male it is 3 to 4 units of alcohol per day. Would not affect, whereas heavier than that it can affect semen quality. Okay, but not conclusively proven to affect fertility as such in the male. All right. uh, in the female as well, what the guideline states is we try to restrict it and avoid intoxication or reduce this amount of intake, and to avoid intoxication to protect the fetus in case she gets pregnant. All right, so they've come to conceive, right? So you want to advise that as a general well-being thing. Additionally, you have smoking is one of the factors which reduces fertility in the females, including passive smoking, and in the males, reduces semen quality. And we do know that although it may not be a causative factor for it, we have seen that those who have male factor subfertility are more likely to be smokers, and smokers affect the semen parameters or quality in those who are subfertile more than those males who are fertile. Okay, so it does affect, but the impact of this is not clear. However, smoking cessation is to be advised by both the TOG articles and the NICE guidelines. They all agree on this because quitting improves general health, and it has also known to improve the outcomes of ART, okay, in the male. Now, caffeine intake. In caffeine, we know that for a couple who is generally trying to conceive, there is no evidence of reduction in fertility, but the ART or IVF success rates can be reduced with caffeine intake. So remember this, it is not for general, but ART success is definitely reduced. And we have obesity. For this, you have to remember it is category 1 obesity and not overweight. It is not 25, it is 30. And for both men and as well as women, BMI in fertility context is always 30. It's always 30, it's never 25 or above. Okay, so for women, weight, if it's higher than BMI 30, can take longer to conceive, and weight loss helps in those women who are anovulate. Okay, so those who are not having ovulation, you advise weight loss, and you advise that in the form of um, weight loss advice is less effective than group programs for the same. So that is a statement which is not tested as such, but yeah, it is one of the recommendations in nice. Okay. Then we had higher body weight, now we have lower body weight. So the BMI is less than 19. Okay. If she is ovulating, well and good, no problems, no effect on conception at all. However, if the periods are absent or irregular, then in that case you have to advise weight gain. That means they are hypothalamic amenorrhea. Okay. Then coming to the male, we have to advise them about tight underwear. Now, can you tell me what NICE says about this? Okay, excess wearage of tight undergarments in the males can raise the scrotal temperature and may reduce the quality of the semen. However, there is unknown benefit, okay, uncertain benefit of wearing or advice on any loose fitting undergarment. So this is never to be told, okay, never to be told in the exams. And as far as occupation is concerned, you should know that there are certain occupational exposures which may impair in the males or the females. Now I've covered this occupational exposure in the male in depth later. And drugs which can be treatment or over the counter or recreational, which you should ask specifically because some of them can affect. So this is your general inquiry into well-being of a couple, all right, and your general history that you should take in a subfertile or a couple who's come to you asking questions about conceiving or fertility. Any questions so far? Dr. Nero?
No, madam.
Okay, great. So we have therapies that we need to start, which is folic acid. And the normal dose for folic acid is 400 micrograms, that is zero point 0.4 milligrams per day. And we have to start this at least 4 weeks or 1 month preconceptionally, okay, till 12 weeks of gestation when she gets pregnant. Hmm? However, there are groups of individuals where we would require to start them on high dose, that is 5 milligrams per day folic acid. Can anyone tell me some of the indications at least?
Ma'am, epilepsy,
Okay.
obesity,
Mm-hmm. Obesity, BMI. What's the cutoff BMI?
mm, more than 30,
30.
more
Okay.
than 35, ma'am? I'm not sure.
Mm. Okay. Never mind. Anything else?
Diabetes mellitus and chronic hypertension
Chronic hypertension. Why?
and a chronic renal disease.
Mm-hmm. Mm-hmm. Mm-hmm.
Preeclampsia, I mean to say preeclampsia in the patient who had preeclampsia or eclamptic attacks in the
Certain?
previous pregnancies.
Are we certain about that? Preeclampsia. How does folic acid affect preeclampsia or chronic hypertension?
Not very much particular about it, madam. But chronic renal disease and diabetes mellitus, in those conditions we can, and if there is any neural tube defect in the patient or patient taking
Are
some.
you sort of sure you're not confusing with this with indications of
Sickle cell
aspirin
disease.
stop?
Sickle cell disease.
Yes. Okay. So I have a nice mnemonic for you here. Okay. This is
Yeah.
my table for your indications for high dose folic acid. Remember, folic acid is given to prevent neural tube defects. Okay. You're not preventing preeclampsia. You're not preventing SGA, IUGRs, and things like that. That is aspirin. And we know that chronic kidney disease is one of the risks for developing hypertension and complications. So that's a whole different thing. But we are trying to prevent neural tube defect. So you have to remember that you give high dose folic acid where you expect a deficiency to occur, okay? Or where the risk factors are there, which would indicate that there's some sort of like a folic acid metabolism issue. Hmm? So, previous pregnancy affected by neural tubes, like a baby affected by neural tube defect. First, the woman herself or her partner has neural tube defect. That is genetic risk for transmission. The woman or the partner have a first degree relative with neural tube defect, family history. And then you have diabetes because this affects folate metabolism, okay, with the maternal hyperglycemia predisposing or increasing the risk of neural tube defects. And then we have anti-epileptic medications which interfere with folate metabolism. So everything has a reason why. Okay, so valproic acid, carbamazepine, phenytoins, they all interfere with folic acid. Hmm? For that effect, there is an antibiotic as well, but it's never asked. So your sulfa drugs, etc., they can also be, but they are not chronic use drugs. So essentially, they would not really contribute to your neural tube defects. Okay. Another thing is BMI more than 30, that is obese, thalassemia and sickle cell anemia, that is hemolytic anemias. Why? Because as the RBCs break down, you're using more and more folic acid. So you develop a deficiency. Malabsorption, like celiac disease, inflammatory bowel disease, bariatric surgeries, and certain antiretrovirals, which are again chronic drugs. So, but again, this has not been tested, so you don't have to worry about it. And the mnemonic that you can remember, God, these are all the indications for using high dose 5 milligram folate. Okay, Dr. Prabhati?
Yeah, yeah, ma'am. Thank you.
Mhm.
Yes.
So the mnemonic you can remember is folated, family history, family or past, then obesity, low absorption, anemia, teratogenic drugs, existing neural tube defects in women or partner, and diabetes. Okay? Mm-hmm.
Good one, ma'am. Thank
You
you.
remember? Okay.
Yes.
Thank you. So then that is a general step or measure we will take, and we have viral statuses that we will do as a general test. So we have not gone into fertility tests as of now, but we are looking at what we will offer somebody who is undergoing fertility consultation. So if undergoing IVF, not in every general couple that walks inside your clinic, all right? If you have decided somebody is for IVF, then they require to have HIV, hepatitis B, and C. Hmm? And if it's positive for any of these, then they would be referred to a specialist. Then again, you have to check everybody for rubella susceptibility. So this is for those who will go on undergo IVF, but rubella susceptibility for all women. Then we have, if they are not immune to rubella, what will you do?
Vaccine.
Vaccination can be given.
Vaccine, and there are how many doses?
Usually one dose only we are giving.
2 doses, 1 month apart, 4 weeks apart, and you have post vaccine, you have to wait for 4 weeks. Okay,
Yes.
for
Mm.
contraception. So after that, you also have to ask about cervical cancer screening, and they will be in the routine program only, nothing specific. And coming to chlamydia trachomatis screen, we need to do this particular swab only, that is NAAT, NAT we will be doing for chlamydia, only if we are planning any sort of uterine instrumentation, such as if someone will undergo IUI, IVF, any HSG, HICOSI, or some sort of like a hysteroscopy and things like that. Otherwise, no, not like a swab for every patient that comes. If this is positive, you will treat it. If you have not done a NAAT swab, and if you want to consider instrumentation, you would want to give them prophylactic antibiotic, because this infection is very, very common, and commonly it is asymptomatic. Okay, so if you're not screened, you want to do this. Otherwise, you would be spreading it inwards, causing a PID. So you want to avoid that situation. Give prophylactic antibiotics. Next, we come to discuss about the HIV, which is a separate slide by itself. I mean, it's not directly in context to anything else in this guideline. But yes, question has been asked on this specifically in EMQ. The question was slightly twisted actually, and it said what not to do. Okay, that was like a negative problem statement was given. So you have to remember that if a man is positive and the woman is not positive for HIV, then you need 4 criteria before you can advise them that they can, conceive with just sexual intercourse. If they fulfill this, he has to be compliant with highly active antiretroviral HAART, and the load has to be less than 50 copies for a prolonged duration of time. viral load has to be less than 50 copies per ml in the plasma for more than 6 months. Why are we saying this 6 months? Because if during this time they are having more than 50 copies at any point of time, say 3 months back they had 100 copies, all right, it's crossing over, your sperm is slow, right, it's coming over a long period of time, it's not made yesterday and today it's fine, all right, so because it's coming over the 3 months at least, all right, so this HIV virus can also remain in the semen, and it will remain in the semen at a higher load if it has been positive in the plasma as well. So remember, for a long period of time, they need to have low viral load, and they should not have any other infection, because other infections also cause leukocytes to appear there in the semen and can cause the HIV virus load of the semen to increase. All right, so heart, okay, viral load has to be low, then no other infection, and if they are allowed to have intercourse only during time of ovulation for the purpose of the reproduction, okay, intercourse as in unprotected, otherwise they would be using protection. All right, if this is fulfilled, then we can allow the couple to, okay, reproduce with just unprotected sexual intercourse. However, if any of these criteria is not met, then it would be advisable, or the sperm washing option which is there would reduce the risk of transmission to the female. If all of these criteria are met, we know that sperm washing can still be done. It can be done, but it will not have any added benefit of reducing viral transmission, but it will reduce the chance of pregnancy. What will it do, Dr. Suchita? Hello? Dr. Suchita? Okay. Hello, guys. Audible?
Yes, ma'am. Yes, ma'am.
Yes, ma'am, you're clear.
Alright. So, if the man is positive, then usually they go through these fertility treatments and specialist clinics. But this is what you must advise. Until and unless all criteria are there, they will have to undergo sperm washing. Okay. Additionally, it makes no more sense to give any post-exposure prophylaxis or something to the woman. Okay, that's it. This is what you need to know about the HIV. There's one past AMQ which has been asked with regards to this. All right. Coming to other viral infections, we can have hepatitis B discordancy as well as hepatitis C discordancy. So you should know that although here we are not doing any sperm washing or sorts, we are offering a vaccine to the woman before they are allowed to have intercourse and to try and conceive. Hmm? And hepatitis C, if the man has, then he needs to be treated by a specialist first to eradicate the hepatitis C prior to trying to conceive. All right. Through the UPSI, risk of transmission of hepatitis C from the male to the female is thought to be still low. Okay. Now, after we have discussed these general measures which can come up, you have to ask yourself the basic question. Now, this couple was asking you a few questions. Why are we not conceiving? When will you do my tests, etc., etc.? It is equivalent to buying a new car and sitting in the car and thinking, okay, is the car going to start? Right? So that brings us to our basic question. How long do we wait before we start doubting that a couple is not conceived. Okay, when do we open the car up and when do we test it? All right. So if a couple, a woman of the reproductive age group, has tried to conceive for 1 year, as it was mentioned earlier, and in the absence of any known factors, all right, she should be offered further clinical assessment at the end of that 1 year period. Hmm. Now, if that assessment is normal, we call her unexplained, and then because we don't have a cause for it, we know that half of those who didn't have any reasons not to conceive will conceive, right? So we don't want to overtreat. So we ask them to wait another year. All right. At the end of 2 years, whoever remains would require treatment. Okay. Now, as mentioned earlier, artificial insemination, those who are undergoing, for all those indications I showed you before, okay, they should undergo 6 cycles in the absence of known factors, and if after 6 cycles they don't conceive, then you investigate. Okay, where this is involving partner. For example, he's having erectile dysfunction, but he's there. Sperm is also there. So it should involve, using his semen analysis will be done, and tube testing and ovulation for her will be done. Okay. All right. We have seen this one before. Now, can anyone tell me this 1 year and 6 months duration, what we just spoke about, is there any exception for this? When do we test earlier?
The woman is more than 36 years. The gap we have to take is 36 years
Okay.
because
Any
then
other?
after 36 years we have, hello?
Yeah. And besides that, what are the other reasons?
Some
Age.
pathology,
Mm-hmm.
pathology.
Very good.
Same-sex couples also.
Same sex couples. Why do you say that? Why same sex couple? What is the logic in that?
I think I got
Like a
confused,
lesbian,
madam.
like a lesbian couple. I mean, female, same sex couple, right?
Yeah.
No, not particularly. Not as per the guideline as such. See, Uh, as I've stated earlier, you have when you're using IUI, the guideline does get confusing, and it separately tells you that there are certain indications only for which you will investigate earlier. Okay, so you have to keep that in mind. Otherwise, when it's a healthy female, why would you start investigating, doing tubal patency tests, and all of that? Even if you're using donor insemination, you do not do that because tubal patency tests are one, HSGs can be expensive, uncomfortable, invasive. You don't want to do it. You do take a history. History is indicative of any problems. Then, yes. Okay. So, you remember it is 36 years or more, identifiable risk factors on history. If anybody is undergoing any treatment such as chemoradiations, known chronic viral infections like hepatitis B, C, HIV, in these cases, we know that we would have to use intervention. So, that is the reason why we are doing it. Okay. This earlier referral is recommended to reduce risk of transmission here. So, you want to investigate for that particular purpose. Am I clear?
Yes, ma'am.
Yeah.
Yes, ma'am.
So now let's look at specific problems. All right. So management strategies and investigations. Okay. Today we will stop at, we will just do your mail in a lot of detail, and then we can call it a day. Okay. So As I've said earlier, this chart comes to reference again and again, so no need to worry about it. All right, we will do a summary of this sorts at the end of everything. So, now in male factor, it is a simple, straightforward one investigation, universal investigation. All others are under evaluation and investigation, but there is one and only one which is being repeatedly used thus far and dictates how your management should be done. Okay, and that is your semen analysis. All right, so what we use is WHO reference standard use, same as the one which is in the NICE guideline. But mind you, that one is outdated. Anybody knows the 2021 updates? Yeah, 2021 updates. Before that, we will look at cardinal rules. You need to ask them to abstain for at least 72 hours. Okay. So at the end of 72 hours, usually the semen analysis is done of abstinence. And if you wait longer, however, we know that motility declines. So after 5 days, it will decline. Hmm? So here what you need to do is analyze it within the hour and it is transported at body temperature if it is produced at home. And fresh semen liquefies usually in about 15 to 30 minutes. So that's one of the criterion for it. Hmm? You can also have low volumes of ejaculate which can be because of retrograde ejaculation or obstruction, androgen in deficiency or incomplete collection. Okay, this may not buffer against the vaginal acidity sufficiently. So the volume is also equally important. All right. So 72 hours abstinence you have to remember and study within the hour, 1 hour. Okay, so this is commonly something which has been put in a SBA. Now you have to, as I was asking you, what is the difference between the 2010 WHO criteria and 2021? Dr. Rashmi, hello, Dr. Rashmi, Dr. Nero, hello.
Something to do with the sperm morphology?
No, actually the normal values of the
Anything?
parameters are different in the two.
Mm-hmm.
Okay.
Mm.
So remember this. One of the memory aids which I used to use is see the sperm is alive, some of it is alive. Then those ones which are alive are dancing in one spot, so motility. And then some of them are dancing and going forward, so forward motility. And the rule of thumb is 60-40-30. Okay, and some of them are perfectly dressed, so they are perfect morphologically. All right, so it is 60-40-34, which is like a rough estimate figure here. What we had was 58%, so plus minus 2 and plus 2. Hmm? So vitality, that is how many are alive. Total motility, that is they are motile, 40. Progressive motility, 32%. Okay, this is 2010. The change which has been brought about is this. Clear so far? So the 58% is reduced to 54 and total motility normal values is increased to 42% and this is reduced to 30% from 32. Okay, so it's 54, 42, 30%. Hmm? Now, don't sweat about this like say they ask you normal value, but they do not form questions in that manner. They will ask you which of these is abnormal, and they will ask you to pick from one sort of like a confusing multiple options. All right. So remember that rather than they will ask you one, okay, the normal value of such is this much, they will always phrase it as pick out the one which is abnormal, and often it'll be a clear answer. Okay, that so would not really matter which criterion that you're looking at, but this is acceptable now because it's been 4 years since the WHO criterion has changed, so it's everywhere almost. Okay, remember it's 15 million per milliliter, and you require at least 1.5 ml, right? If you produce very little semen, we have seen that there'll be a problem. The problem will be that it will not cope up with the vaginal pH, right? So you require good quantity. So per ejaculate, you should have ejaculate as in, say he's per ml 15 million, but he's producing 3 ml. Okay, so that makes 45 million per ejaculate. Got it? So per ejaculate, it has to be 39 million. Now, this also you will not read the question carefully and you will mark it wrong because they will say 15 million spermatozoa per ejaculate, and then you'll be like, okay, I see this figure, and then you will get confused. All right. So don't, or you will say, oh, two options were right. Which one should I have? So they do not do that. In fact, you have to read very, very carefully. That's what is essential. All right. Okay, everybody understand and remember the alive motile forward? Yes? Dr.
Yes, ma'am.
Pallavi? Yes?
Yes, ma'am.
Great. So now we have different forms of abnormal sperm here. Okay, in terms of morphology, it's a little cartoonish sketch which is there. But essentially, this has not been asked, but was there in your old strategy, not even like in the updated strategy mentioned, but you should know what each one means because sometimes they can provide you or confuse you between aspermia and azoospermia. What is the difference? Aspermia, azoospermia. Yes? Come on.
Spermia is no semen and azoospermia is the sperm count. There is no sperm count.
No sperm at all. Oligozoa is less sperm count. Polyzoospermia is high sperm count. So poly meaning multiple. Astheno is they're snoozing, slow. Okay. And teratogenic. We know that terato means something is abnormal, right? So teratogenicity, abnormal. Okay. And globo is self-explanatory. It is actually this guy who's all globular here. This one. Okay. All right. So you have globozoospermia. Acrosome is completely absent in them. So that cap, what they have, making them pointy, that's not there. All right. And in necrozoospermia, as again we understand self-explanatory, dead sperm, hypospermia, less semen, hyperspermia. See, if we remove the zoo, then it's got to do with semen directly. So hypospermia, less semen, hyperspermia, more semen, leuco, white cells, and hemato is red cells in C. Okay. And aspermia, as we said, no semen at all. Okay. So N ejaculation or retrograde, pure retrograde. So, what should you not do? Apart from this, in fact, semen analysis, you are not supposed to do any primary investigation as such. But if this comes abnormal, the talk tells you you need to investigate further because you need to find the cause for the same. So, we have you don't do anti-sperm antibody, you don't do postcoital testing because none of these have any satisfactory intervention that we can do to improve fertility outcomes. The treatment modalities for male factor, subfertility remain simple, straightforward. Only four options are there. Five, but the fifth one which doesn't get picked up in part two, it will be there in your part three. But you have to understand four modalities. What are they? Can someone say? Guess. Four modalities which we will talk about.
Active, motile, forward moving, and good morphology.
Mm-mm. No, no, I meant to say treatment modalities. Nonetheless, we will come to that in a bit. But good, yeah, paying attention, Dr. Pravati. Yeah,
Yes, ma'am.
okay. All right. Hopefully, it's interesting enough to remember. Yeah, so
Yes, ma'am.
mm, because it's like we know part two is like a lot of volatile information, just a lot to begin with. So we have semen analysis, which we have done once, and we have found that the parameters are abnormal. Now, can someone tell me what is mild? What is all this mild and moderate to severe semen abnormality? Where are these definitions given? It's not a straightforward answer. Actually, inside the NICE, the termination, the terms definition, if you go into that zone, they have just defined mild male factor as less than any one or more parameters being less than the fifth centile by the WHO categorization. That is, these are the normal values. So these are less than fifth centile values. Okay. When they say one if one parameter is abnormal, one is less than the fifth centile, then you can call it mild male factor. Remember that if it is more than one, two parameters are abnormal. For example, I am saying that the motility is less, okay, and normal forms are also less, so they are not moving, they are 25% progressive motility and 1% normal. Or if I say that the count is less than 15 with 1% normal forms. Okay, so now I'm saying that not just that the count is insufficient, but they are not even normal. So that makes two parameters abnormal, in which case it would be severe, okay, moderate severe, whatever it is. And mild, it will be only if one parameter is coming out abnormal. Okay, now practically speaking, the motility and all are affected subsequently and the count is affected first, right? Everybody agrees on that?
Yes,
Yes.
ma'am.
Yeah, so we go by this particular definition also, that if the count is severely low, so 15 million or above is normal, normal as in more than the fifth centile, but if it's less than 5 million, okay, that is one centile, that is considered severe oligo. Okay, so azoospermia is severe. Severe oligo is severe abnormality. And if you have count less and other abnormalities, that is two parameters or over that being abnormal, then you are worried about that semen analysis report. Okay, got it? So, what you want to do, if it is just mild oligo, that is between 5 to 15 million, all other parameters normal, you repeat it later. You repeat it after 3 months, because you're thinking something might have gone wrong transiently. He had a illness, sickness, he had a flu, maybe body didn't produce sperm enough in the last 3 months. But we are giving a chance, we repeat it in 3 months. However, if we find as I described, okay, it's more severe abnormality than that, you want to confirm it right now. because you're not going to waste any more time. Okay, 3 months later, it's not going to improve. Excuse me, clear?
Yes, ma'am.
Yes. Yeah, okay. All right. Any doubts, Dr. Nero?
No, madam.
Okay. So now we come to the hypothalamic pituitary gonadal axis. Okay. So now your male factors, you have to understand treatment modalities based on the cause. Now this part is pretty simple if you just understand the logic of things and why a particular modality is used in a particular condition. Okay. So we have the hypothalamus, which basically sends signals to the pituitary, which will in turn synthesize your FSH. F is follicle, right? For the ovary, it will stimulate your follicle to develop oocyte. In the male, the FSH will go to your S cells, which are sperm producing Sertoli cells. Okay, so S FSH, right? Follicle stimulating will go to the Sertoli cells and will stimulate the spermatogenesis. Alright. LH on the other hand is a luteinizing hormone which will go to your Leydig cells, L for L, okay, and will synthesize testosterone. Alright, so FSH for sperm, LH for the testosterone. Both go to the testicles, and these two different cell lines they will act on. Hmm? Correspondingly, we have the same thing happening in the females, which we are not looking at right now. So now, if there can be failures at three levels. One, you're not having enough GnRH or FSH-LH. So you're failed at the level of the center or the brain and pituitary. So if that happens, you're not producing either testosterone or sperm. Alright? So that is called as your pre-testicular. Then you'll have your testicular. FSH-LH signals are there. In fact, they are excessive because testosterone is not getting produced at the level of the testes. Testes have failed and they are not producing sperm, they are not producing testosterone. So more and more signal keeps coming. FSH, LH increase, testosterone low. This is testicular. Okay. And then we have this is signaling is fine, everything is fine, testosterone is fine. But the sperm which is produced is not moving downstream. So we have obstruction, which is your third main cause. Okay. In this, what will happen to the hormones? Normal. Everything will be normal. Okay. So how we identify, and your most important questions and the bulk of the questions will be based on this particular diagnosis schema, and they will ask you which is the cause in that particular like whether it is pre-testicular, testicular or post-testicular. Okay. So sperm is formed in the seminiferous tubules from spermatogonia. This is all I discussed before. Okay. All right. So the full process of spermatogenesis takes about 12 weeks or 3 months. This is why we earlier said about repeating the semen analysis in 3 months. Okay. This is your chart which I have made for you with examples. Can you read this? Can people see this?
Please make it
Yes.
a bit
Yes.
bigger, ma'am.
Um,
Quite
sure.
small.
Okay. So try to stay on the laptop whenever because notations, it will be easier for you to grasp also. So as I said earlier, pre-testiculars will have low, both will be low. Testicular will have high FSH-LH and low testosterone, and post testicular, obstructive, everything will be normal, or FSH-LH may be very mildly increased. Okay. Apart from that, we can have, causes because of, say, Y chromosome deletion and things like that, where actually, although the signals and the hormones are normal, the sperm, by itself is having defective production, wherein again the FSH-LH testosterone will be normal. Okay. And you can even have sexual dysfunction. We have seen that there it can be because of low testosterone also, or otherwise people can have normal. Okay. The exception to the rule, and there is only one, is exogenous androgens. You can't call it. Actually, you can classify it as a pre-testicular cause. However, I put it separately here because in this, and this is the only place where you will get high testosterone but low FSH. Okay, so it's a very specific sort of a cause. So I've separated it out from here, but by classification it goes here. Okay. Now, all these causes which are there, people are not going to ask you to enumerate them or have them committed to memory and things like that. But you should know that anything which affects the center, for example, Kalman syndrome, pituitary adenomas, tumors, then hypothalamic tumors, hyperprolactinemia, thyroid, okay, hemochromatosis, all of these will not produce your signals and thereby not produce the sperm and testosterone. Okay. Then you have primary testicular failure. Okay. By primary testicular failure, we mean something is wrong at the level of the gonad. Okay, gonad is shrunken or not producing, which means you can have Klinefelter, Y chromosome deletions, Noonan syndrome, something like cryptorchidism, or infections, trauma, varicoceles, chemotherapy, radiotherapy, which affected testicles, or testicular tumors, and again, one of the leading causes. What is the most common cause of testicular pathology?
Moms.
Mom's most common cause.
Idiopathic.
Idiopathic. 50%.
Idiopathic. Yes, yes, very good. Idiopathic. In fact, idiopathic is overall the most common cause because half of the cases of azoospermia you'll not have a cause, and of the testicular causes, 66%, two-thirds of the causes, they will be idiopathic. There won't be any reason why it happened. Okay. All right. So then we have post-testicular, which can be any obstruction like vas deferens, congenital absence, Young syndrome, vasectomy, infections, iatrogenic injury, so on and so forth. And as I have said earlier, sperm function disorders and sexual dysfunction. These causes you guys all know very well: erectile or ejaculatory dysfunction, poor timing or frequency, and like things like diabetes, multiple sclerosis, spinal cord injury. These can cause ejaculatory problems and erectile problems. Okay, that by causing male factor subfertility. All right. Don't get worked up looking at all these causes. We will see them coming up in the different questions in the QBank also. As you're solving, you can see from the website and all of those things that how the questions are actually phrased. And because of the questions, I have actually sort of given you this particular slide here. This one, come to it in a bit. Okay. So don't worry about committing these to memory as such, but you should know what category they come under and what happens to the hormones in each of these cases, because that's very important to understand. Etiology and incidence male factor, again these figures I was talking about earlier, they do ask these, and this particular TOG article 2013 assessment of a subfertile male was a very very important TOG article. Subsequently authors have also written one in 2020 which is not very important from exam point of view. Okay, so the male factor alone contributes to 30%. The subsequent article changes this percentage, but don't worry about it. We are still sticking to this because the NICE guideline also sticks to it, and they have not made any changes anywhere else, even in the patient literature. So we are sticking with all of these figures. Okay. So incidence is 50% idiopathic overall, and as I've said, 66% are idiopathic from the 60% testicular causes. Okay, the least is pre-testicular, meaning signals not coming is very very uncommon. Okay, less than 1% is your pituitary and your hypothalamic causes. Hmm? You can have the rest is 40/60, which is obstruction in 41% of the cases. This is of course excluding vasectomy, because vasectomy, if you include, it is deliberate blockage, so it would increase the incidence of this. So otherwise obstructive fortunately is still quite high, but unfortunately, why we say unfortunately, why this is very unfortunate?
Because we don't know the reason.
You don't know the reason is another thing, but unfortunately, the majority is testicular causes, and the majority you don't have any straightforward treatment. You can't increase the count. You have no way of doing any therapy to increase the sperm count. Okay, that is why it is unfortunate. Pre-testicular, which is treatable with other than your artificial reproductive techniques. Okay, that brings me to the four modalities which you will pick in your exam. One, okay, is medical therapy. What is that? Mm-hmm. Medical therapy is gonadotropins. Okay, the only medical therapy is gonadotropins, which is approved, and it can only be used in the least number of people that you can have, that is pre-testicular causes, right? You use FSH and LH. Okay, all right, recombinants, and you are trying to stimulate the testes which are functioning fine. The testis is functionally all right, but it's just not producing anything because it's not getting FSH. So you give pulsatile GnRH, okay, and pulsatile GnRH would fix the issue because that pulse is not coming. All right, so you have, that is your first modality. Got it, everyone, guys?
Yes, ma'am.
Yeah.
Yes, ma'am.
Okay, so now this is something by the by we'll mention. Okay, we'll mention this and move on. Okay, so what does NICE tell you about varicocele? Okay, varicocele are basically refluxing spermatic cord veins. Okay, they form a bag of worms sort of feel in the scrotum, right? They raise the temperature locally and they alter steroidogenesis. This is how they are thought to, okay, not proven, but thought to affect the semen parameters, because we know that 25% of men with abnormal semen parameters have varicoceles, versus it is only seen in 11% of or 12% of those who have normal semen parameters. Okay, NICE does not say that you do varicocelectomy, okay, because there is no benefit. There is improvement in semen, but no proven benefit on live birth or conception rate. Okay, but the TOG article differs in this. Okay, they have said that there is a significant increase in the or improvement in semen parameters as well as significant improvement in the pregnancy rate. Okay, if you do a varicocelectomy, so it is a pick and choose sort of battle. It has fortunately not come up, okay, because there is a controversy about it. But I would suggest we go by nice guideline and do not recommend it, okay, as one of the first things if it comes up in your question. Hmm? So, all right. Now, these are the factors which affect male coming from your TOG article. We have mentioned some of these in the general factors which affected, right? So, age, then your obesity and anabolic steroids, alcohol, we know that. Heavy but not moderate. So, it's the same recommendation. Tobacco, they have said to stop. Okay, advise stop smoking because tobacco reduces semen parameters. Cannabis also mm, affects semen parameters, but not fertility rate directly. But you advise to stop. Okay, advise to stop. Cocaine, amphetamines, opiate, they reduce libido. Erectile dysfunction may be there and can result in male infertility. Oxidative stress is also known, but then again, that there is no particular recommendation for using any multivitamins or antioxidants. Okay? Okay? So don't use anything. Nothing is proven conclusive. All right? Now, coming to your history, this is more relevant for from part 3 perspective, but for your questions, we come directly to this. Okay. Now there are two slides here which will show you those keywords which can come up in your exam. Slide 2 is not asked commonly. Okay. The only thing important from slide 2 is your cystic fibrosis association with the congenital absence of vas deferens. Okay. But apart from that, we have all of these buzzwords. Okay. Can you guys see this? Mm-hmm. Let's go one by one. Okay. So if somebody gives you a bag of worms, feel in the scrotum, it is you're looking at varicocele. It worsens
Varicocele.
when standing and improves when supine. Okay. If I were to give you buzzword anosmia, what is it? Anosmia.
Cystic fibrosis.
Anosmia is cystic fibrosis.
Kalman syndrome.
Kalman
Kalman
syndrome.
syndrome. Very good. Okay. So we have anosmia or hyposmia. What is this? This is lack of smell.
Yes, ma'am.
Yeah, it is lack of smell because the neurons which migrate from that, I think the thing is called as olfactory placode, migrate to the hypothalamus and to the olfactory, area at the same time. So this is what is deficient there. That's why you don't have smell and hypothalamic neurons. All right, that is Kalman. Then, if I gave you visual field defects, galactoria, headache, okay, nipple discharge, okay, then
Prolactinemia.
Hyperprolactinemia.
hyperprolactinemia. Alongside with this, we give headache to you, it is a pituitary tumor, okay. If we don't give headache, it is hyperprolactinemia, you can choose, okay. Hmm? So, if we give you very well built muscular with acne, raging testicular atrophy, anabolic steroids, okay, and then again you can have thyroid with dry skin, cold intolerance. These are the two most common things they'll give you. And in hyperthyroidism, they'll give you heat intolerance, weight loss, tremors, things like that. Okay, got it? Now, one of the commonest things they will say is tall individual, okay, small, rubbery, firm testicles, all right, and gynecomastia, okay, lanky build. What is it?
Fan filters.
Yes, very good. Okay, all right. And we have something which corresponds to Turner's syndrome, but in the male. All right. Turner's is actually a sex linked, right? But in Noonan syndrome is actually a autosomal dominant, but you have the same morphological features like a Turner's. So short stature, webbed neck, cardiac defects, so on and so forth. Especially your truncus arteriosus and things like that, which is Noonan syndrome. Okay, so then again they can have your hypothalamic causes. Hmm? And yeah, Y chromosome microdeletions actually will not have any systemic manifestations. They'll just have abnormal semen parameters, and they will usually have very severe oligozoospermia or azoospermia altogether. Okay. In mumps orchitis, you can have swollen, painful testicles, not commonly asked, torsion, not commonly asked, varicocele, I have already told. Okay, so this slide is more important than this one. Okay, so this one you can just go through, not like it comes up very often, but yes. Okay, all right. So the other investigations that we will do down the line is, of course, we want to check. We did semen parameters, right? Then we said we needed to categorize based on FSH, LH, testosterone. So those, plus we do thyroid and prolactin wherever necessary or relevant in terms of like if your history indicates and so on and so forth. Right? The TOG article, however, mentions that if there is severe oligozoospermia, also you do a prolactin level in all those cases. Hmm? Am I clear so far, Dr.
Yes,
Nero?
ma'am.
Yeah,
Okay.
good.
Madam.
And we have, sorry, hello?
Madam, clear. Yes, madam.
Yeah, okay, all right. So we have, if for other reasons to test above is sexual dysfunction like impotence, lack of libido, and things like that. Then we have genetic causes, which is the karyotyping that you would have to do. And the most common reason, genetic reason that you can get is Klinefelter. So now the most common reason would be idiopathic. The most common genetic condition leading to testicular failure is Klinefelter. Okay? Got it? So your question, again, you have to read very, very carefully. Hmm? So you have YQ microdeletions, that is the long arm microdeletions of the Y chromosome, and often 5 to 10% of those associated with severe oligozoospermia, that is less than 5, the count is, and azoospermia in 10 to 15%, meaning zero sperm, no sperm at all. The sub-regions, now they have studied this, and why this is important is that the azoospermia factor, okay, if you have the region C abnormality, then it has better prognosis, because on a testicular biopsy or via testicular extraction you can at least get some sperm. But in regions A and B, you are azoospermic and you have no sperm at all. So you only can then go for, what is the option? If there's no sperm at all,
Donor sperm.
donor sperm. Very good. Okay, so you go for donor sperm. All right. Other genetic condition is cystic fibrosis. When again they will, the buzzword for this will be idiopathic or non-palpable vas deferens. Non-palpable vas deferens. Okay. Now, apart from that, scrotal ultrasound, not too much of a use, but in case you palpate some tumor, or if you are suspecting varicocele, you can do a retrograde flow on Valsalva using color Doppler, and you can take a look at that as well. And a testicular biopsy. Now, why testicular biopsy is such? Is it diagnostic? Yes, but at the same time, more use of testicular biopsy is to establish what can you do. Do you go for donor or do you use ICSI? Okay, excuse me. Yeah, so what the testicular biopsy will allow you to do is see if any at all sperm is available inside the testis, and if so, can be extracted or aspirated, or what can we do with it? All right. So, if there is severe oligospermia, oligozoospermia, or azoospermia, then next step would be to go for a testicular biopsy. So we do this, and we have spoken about this in a lot of depth, so I'm not repeating. Biopsy, and then we see retrieval. Now, if it is reduced, okay, hypogonadotropic hypogonadism. What was our solution here? We just gave the signals, right? So you gave GnRH, pulsatile GnRH. Okay, all right. If that does not work out, you do IVF. Okay, that doesn't work out, ICSI adoption. This in that order. But your first option, single best answer, or EMQ first option modality would be GnRH. Okay, obstructive. What would you do in obstructive? Is there sperm or no sperm?
Sperms are present, but they are not coming out.
So what will you do?
Surgical retrieval can be done by
With
aspiration.
with
Retrieve the sperms.
now I said I've given you from A through K, and there is IVF, there is IVF ICSI, there is donor insemination, there is donor IVF, there is donor IUI. What will you choose?
You can do ICSI in those patients after sperm retrieval
Okay, why ICSI?
because that gives good result for fertilization.
Okay, what is the difference between ICSI and IVF
IVF
in terms of?
we leave the sperms in the tray of ovum, and in
Mhm.
ICSI intracytoplasmic injection to the ovum is given so that the sperm meets the ovum in the cytoplasm.
Okay, when you say for obstruct, we asked you about obstructive cause. So the sperm is available in good quantity, even if you were to aspirate it.
No, that not that much as normal.
We are, if you are talking about primary testicular failure, okay,
Hmm.
the answer which you are giving me would be fine.
Okay.
But when we are saying it's an obstructive cause, or it is mild male factor, okay, like a mild semen abnormality in the parameters, the
Hmm.
first thing to do would be IVF only, not directly ICSI. ICSI has very specific reasons why you need to do it. Okay,
Yes.
so although we have our ICSI being mentioned as all in all of these situations here, we know that you wouldn't directly go to ICSI. One of the reasons for doing ICSI, or one of the indications for ICSI, in fact, is IVF fertilization failure. So if you're doing IVF And during this time, you are seeing that fertilization is poor. You're not getting good embryos. Okay, they are not forming. Now you do XC, not directly.
Okay.
Okay, reason is the cost. The guidelines have to be aligned with the costs involved with each of the things. So,
Yes.
and the other thing is, even this is mentioned in fact in the TOG, which is there. ICSI improves fertilization. What you said was right. ICSI improves the fertilization rate, but between IVF and ICSI, if the embryos are anyway forming, then the clinical pregnancy rates and the live birth rates are not affected, not different between the two modalities at all. Okay, so it does wherever fertilization is failing at IVF, then you do ICSI. Okay, so that's one of the indication. So we have medical treatment limited role, we have discussed this, and then we have primary testicular failure. Nothing can restore fertility here, so you try to do some sperm retrieval and then you put it for ART. Oftentimes this, okay, is ICSI first here because the semen quality is very poor. Okay, semen quality is very poor, and if at all you are able to retrieve any sperm, only then you can do ART. If I gave you a question where I'm saying there is azoospermia on this on your semen analysis, and I've not given a biopsy result at all, and I ask you directly, the question is saying which is the treatment. What is your answer? It cannot be ICSI because you are not speculating or assuming that sperm will be there. They've given you azoospermia and they said parameters are that or FSH LH is high, testosterone is low. So you know it is testicular failure. Your first commonest answer has to be assume primary testicular failure and you have to say donor sperm. Got it?
Yes.
But, however, if they say there was primary testicular failure, biopsy has been done, which is showing some like sperm is available. Now your answer changes to ICSI.
Excellent.
Got it?
Okay.
Okay. So that's how you mark your questions.
Mm.
So you have your urological surgeries. Again, I've spoken about this particular thing. And then you have your sperm retrieval. Now, Tessa is aspiration, meaning that it's a needle which is put and the sperm, which albeit available in more quantity than Tess E, is aspirated out. And whereas in Tess E, it is extraction, meaning that a piece of the like a biopsy is taken. Okay, in Tess E, biopsy is taken and the sperm is like literally picked out. Hmm? And yeah, so in obstructive causes, because the sperm is produced normally and is structurally normal, it has almost 100% success rate. Okay, if we extract or aspirate, okay, and we do get a good amount of sperm, but in non-obstructive, that is testicular causes, about only in about half the cases we can get any sperm at all. Okay, all right. This is slightly become blurry, I think, but it serves the purpose. Intrauterine insemination is when the sperm is directly put inside the uterus. Classical IVF is wherein the egg is left into the petri dish and you mix it up with the sperm. The sperm is supposed to be good enough in number and quality so that it can go and fertilize the egg. Okay, so you do this in milder male factor, whereas you take a sperm and you poke it inside the ovum directly, which is called as IVF ICSI. Okay, now this is the difference between the three. This one you will do in severe male. Okay, severe male, and anytime that you are retrieving it from say testicular biopsy and things like that, basically you have very few spermatozoa. Okay, so you use ICSI in that case. Now, if you have good sperm here, as I had told you earlier, if fertilization did not occur with a classical IVF, meaning the sperm, they are there, you tried, they didn't fertilize. Okay, next you try this one. You go here. Failure of fertilization, you go here. Okay, all right. So again, we have a nice table here which should be able to cover all your EMQs, all your SPAs as well. So you have your pre-testicular, how you treat it, testicular, testosterone replacement, plus you can have sperm retrieval ICSI, donor sperm if azoospermia, and mild, you do in vitro fertilization. But what is the first thing you will say now if I am all right? So a male comes to you and you have evaluated female partner is ovulating, female partner's tubes are patent, he is having count of 13 million. Okay, at the end of now you've evaluated at the end of 1 year. Your question asks you what will you advise now, and your options have different combinations: IUI, donor, sperm, IVF, ICSI. What will you say? What's the answer? Dr. Prabhati.
We can try because the patient is azoospermia, so we can
No,
try
no,
with
no.
IVF.
13 million. 13 million, not ASOS.
Okay, 13 million. We can try, madam, IVF in those patients.
Okay. Dr. Suchita, Dr. Pallavi, Dr.
Well, we
Niro.
can do IUI.
IUI, okay. Dr. Niro.
IUI, madam.
Okay. All right. No, you will not. See, listen to the question carefully. You have evaluated at the end of 12 months. Okay. There is mild male factor. You have to
We should
treat
try.
mild male
Mm,
factor, mild endometriosis, unexplained, will be try for another year.
mm,
Okay. Try another year. That doesn't work. Now IVF. Okay.
yes, ma'am.
I thought 2 years. That's why I answered IVF.
Huh.
Sorry. Thank you.
So at the end of 1 year, when you've evaluated, you've waited. Now you're doing IVF. Okay. If IVF does not fertilize, next step, next question will be okay. The cycle was tried that no fertilization happened. Now you do ICSI.
Pixie?
Okay.
Hmm.
Now another question. Twist in
Hmm.
the same write up, I will tell you. Okay. Uh, so couple is the same couple. Now you have tried IVF, okay, and then the question says the implantation was poor. What is the next step? IVF. You know why? Because the fertilization happened
Hmm.
nonetheless. Okay, so you try another IVF. It was not fertilization that was a problem. So just one word in the question makes a huge difference. All right, so please read, please have your concept very clear. All right, now surgical correction in post testicular if feasible, and sperm retrieval and ICSI, and treat any infections as applicable in post testicular and sperm function disorders. In severe, we have ICSI, we have said that. And in mild, we have IVF after 2 year interval. All right. Now, sexual dysfunction, the method which is there is you can use phosphodiesterase 5 inhibitors for erectile dysfunction, such as your sildenafil, but not a common question, not asked as such. All right. This is Dr. Yes, Dr. Prabhati. Yes, you've raised your hand.
Ma'am, how many cycles of IVF we are going to try before going for ICSI if the patient has the problem?
No, 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 no. ICSI is only if IVF is not able to give you a fertilized embryo.
No, you told us that if the implantation failure is there, we are going to try for another IVF cycle.
No,
So
you
how
will
many IVF
continue
cycles?
as long as you're getting embryos and you
Okay.
have good quality embryos. You are
Okay.
not going to do ICSI again. You are going to continue with the IVF. And now the number of cycles of IVF at all is dependent on the funding criteria. And if they are self-funding, and then it doesn't really matter. Okay. So the
Okay.
limits on the IVF number of cycles is actually dependent on the funding criterion only. Hmm?
Okay. And the age of the patient as well.
Yes, the age defines the funding criteria,
Okay.
whether you qualify or not. Yeah?
Okay. Thank you.
So, yeah. Uh, All right. So, what do you not offer? You don't offer any anti-androgens or gonadotropins, androgens, bromocriptine, kinin enhancing drugs, none of these. Okay. And for anti-sperm antibodies, no corticosteroids proven effectivity. Do not give antibiotics for just having seminal leukocytes unless you have an infection, which is proven. And as far as varicocele is concerned, your answer has to be no surgery. Okay, no surgery. And management of ejaculatory failure would be through the vibrators and things like that. If you can achieve ejaculation through that, then we can prevent invasive sperm retrieval techniques for IVF, ICSI, whatever. Hmm? So this is the same thing, whatever I explained to you, but in a more systematic approach, you can revise with this. So you have your semen analysis. First semen sample will be there. Then reassure if it's normal and do female evaluation. And if it's abnormal, depending on the abnormality, then you will repeat in 3 months or repeat immediately. Okay. And then if you have a pretesticular cause, then GnRH analogs. If you have a oligospermia, then mild to moderate, then IVF. If severe or OATS, then ICSI. Okay. And if you have azoospermia, again, it depends on the cause. Okay. So this is how you are going to evaluate your question. Okay. How you will reach the correct answer. Hmm? Okay. All right, the same thing in this. Hmm. All right, so we have done this, and I had promised that I would tell you about the different investigation timelines when you are trying IUI, right? Okay, so IUI was being used for all of these indications with either we had a donor or partner here. Okay, remember this, like male sexual dysfunction, female sexual dysfunction. They're actually having a partner here. Here, same sex couple, single woman, partner isn't even available. And cryopreserved male gametes partner is again there. This is partner's semen. And infectious diseases, again, partner is available. Okay. In these indications, okay, the green ones, okay, you do unstimulated IUI. What is unstimulated? No clomiphene citrate, no letrozole, natural ovulation, IUI, okay, 6 cycles. If they don't conceive, then you do tubal test, you do ovulation confirmation, you do semen analysis wherever the partner's sperm is being used. Now, if you have used donor, then taken for granted that it was already analyzed. Okay, all right, but that's a different thing. Huh? If you're using partner for sexual dysfunction, you do, since everything else is normal with that couple, you've given them benefit of doubt. You think everything is normal. You've taken a history. You go ahead with the IUI. If this is normal, now you have unexplained subfertility. So, meaning you don't have a cause. Why that IUI did not work? You don't have a reason. All right. So everything is normal. Tube is normal. Ovulation happened. Semen was normal. So you offer another 6 cycles. Okay. Clear, Dr. Prabhati?
It's clear.
Clear. Yes.
Yes.
Now I give you another set of indications, which is donor insemination, which we are using because the partner was there, but partner was azoospermic, or they didn't want to do IVF-ICSI. Okay,
Mm,
so in this situation, or where partner is at risk for transmitting infection, genetic disease, or rhesus isoimmunization to the baby, in these indications, they have said you confirm ovulation first,
mm,
okay?
mm,
Then you take history at the time.
mm,
If tubal damage is suspected, only then do tubal patency test,
mm,
okay? So
mm,
you check ovulation. You take history. If
mm,
history is negative, you don't do tubal at this point of time.
mm,
Then you do three donor IUIs.
mm.
Three.
Okay.
And then if that didn't work, you test tube.
Okay.
Got it?
Okay,
So
ma'am.
this is given very much so later in the NICE guideline.
Mm.
All right?
Yes.
Yeah. So this is the algorithm for it. But in the green indications, you do not do any testing. Directly 6 cycles, then not successful, then test everything. However, in these indications, please note you test ovulation, you take a history, you give 3 cycles. If not happening, then test tubes. Okay, and you are using donor anyway, so semen analysis is not a question. You are using donor.
Mm,
Donor semen obviously is a good quality. Okay, so that concludes my male subfertility. All right. So um, we have discussed unexplained, so let me just cover that up. And it's just one slide anyway. So it's like that 1 year UPSI or 6 cycles, and then clinical evaluation when you need to investigate earlier. Okay. And if all investigations are normal, then you give expectant for 2 years. Okay. UPSI or 12 cycles of IUI. And if that's not working out, you do IVF.
mm.
Okay. This is also true for mild endometriosis or mild male factor.
Okay.
Okay.
Yes.
Right. Yeah. So before we go on to, actually, we can cover tubal and uterine and ovulation in the next part of it. All right. In the next lecture. Right. I think it's quite late as well. So I hope that this was useful to you guys as a session. Dr.
Yes.
Prabhati, your hand is up.
No, no, I'll put it down
All
now.
all right.